So one of the reasons why preconception health is so important is because this is a targeted way to address the very real problem of infant mortality. We know that in the U.S. that there are minority groups that are 2 to 3 times more likely to have a risk for preterm birth as well as low birth weight. And we know that for babies who survive that period, these problems will go on to manifest later during the school-age years. And that's something that we should be able to fix. Well, I think the traditional paradigm in terms of prenatal care has been a focus on healthy mom, healthy baby. The new model is that we want to address moms before they become pregnant and address their preconception health, because now we're learning that early prenatal care is often too late prenatal care. The conversation about preconception health is not a conversation about how to practice medicine. We know that physicians are practicing medicine well. The life course perspective allows us to look at health outcomes in a broader view. So instead of looking at symptom and disease, it takes into account the social determinants of health, as well as environmental factors, genetic factors, and health factors. For example, education, poverty, housing, emotional health, mental health. We like providers to think about the continuum of health and not a discrete point in their health. We know that sometimes patients have reasons that they want to deliver their baby early that are not necessarily medical. And we also know that sometimes patients are under the impression that 38 weeks is close enough. We want to continue to focus on no elective C-sections before 39 weeks, and we want to focus on a normal pregnancy is a pregnancy that can go to 39 weeks. And unless there's a medical reason, we really should not be delivering babies before 39 weeks. I think the bulk of the time that we're focusing on symptom management and we're treating disease, and I think that's very valid. But we also have to find a way, even in our busy schedules, even with seeing all those patients, to remind ourselves that, hey, I don't have to do all this all alone. I don't have to do it by myself. I do have resources. Our public, private, nonprofit, and community-based coalitions, which are already in existence to help us help them. I'm going to refer my patient to those resources, and I'm going to follow up. And then I can move on to the next patient.